Hello everyone, and welcome to our webinar, Relationships, Intimacy and Communication in Multiple Sclerosis. We have three amazing presenters today, Dr. Margaret McGrath, Dr. Aaron Boster and Dr. Sinead Hines. And my name is Peter Butler and I'll be the facilitator today. Now, in the spirit of reconciliation, MS Limited acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. And we pay our respects to their elders, past, present, and emerging. We also express gratitude that we share this land today, sorrow for the cost of that sharing, and hope and belief that together we can shift to a place of equity, justice, and partnership. So on to some introductions now. Dr. Margaret McGrath is a senior lecturer at the Sydney School of Health Sciences, Faculty of Medicine and Health, where she's engaged in research and teaching in the broad area of chronic disease and acquired disability. Dr. McGrath has a background in occupational therapy and has achieved national and international recognition for her work in addressing the sexual rehabilitation needs of people living with chronic disease and acquired disability and their partners. Dr. McGrath leads the Sydney Sexuality Group. This is an interdisciplinary group of health professionals and researchers who aim to improve knowledge and skills of health professionals and evidence-based services provided to people with chronic disease or disability and their partners in the area of sexuality, relationships, and intimacy. Dr. Aaron Boster is a board-certified neurologist specialising in multiple sclerosis and related CNS inflammatory disorders. He decided to become an MS doctor at age 12 as he watched his uncle Mark suffer from the disease in an era before treatment was available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate at Oberlin College. He earned his MD at the University of Cincinnati College of Medicine and completed an internship in internal medicine and residency in urology at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by MS. He's been a principal investigator in numerous clinical trials, trained multiple MS doctors and nurse practitioners, published extensively in medical journals. He lectured to both patients and providers worldwide with a mission to educate, energise and empower people impacted by MS. Dr. Sinead Hines is a lecturer in occupational therapy in Galway. She started in this role in December 2015 following the completion of a postdoctoral research fellowship at the University of British Columbia. Prior to this, she worked for the NHS on a large occupational therapy trial for people with dementia. She completed her PhD at the University of Cambridge, based at the MRC Cognition and Brain Sciences Unit in 2013. So I will now pass you over to Dr. Boster, but prior to that, I will launch a poll. And you can see those, Dr. Boster, those responses?
I certainly can. So just for those of you listening in, have you and your MS provider discussed sexual concerns? Please select one of the following. Yes, I brought it up. Yes, they brought it up. No, but I wish we had. No, and I would not like to discuss that topic. Please choose your appropriate answer.
I'm excited to see what the results are.
So am I.
So 21%, yes, I brought them up. 11% say yes, they brought them up. 64%, no, but I wish that we would. And 4%, no, and I would not like to discuss this topic.
Good evening, howdy, and my name is Aaron Boster, an MS neurologist in sunny Columbus, Ohio. I'm lying, it's not sunny here. I'm absolutely delighted to be joining you in my future, because here in the Midwestern United States, it's still Wednesday. So it's kind of awesome to be talking to you in Thursday. Thank you for participating in that polling question. And it's not surprising that the majority of patients fell into a category where, gosh, they wish they could talk to their provider about concerns of intimacy, relationships, and sex. And all too often, that's a common theme that we're not addressing these very, very important concerns. Let's be honest with each other. If you would like to improve the quality of life of an adult human, one of the very best ways to do that is to improve the bedroom, is to improve intimate relationships. And unfortunately, in the setting of multiple sclerosis, all too often the down theres become affected. You know, the down theres, bowel, bladder, and sexual function. And it's in some cases, a cultural taboo topic. It's something that we're not supposed to discuss. And people can feel apprehensive or simply avoid the topic and watch their quality of life plummet. I was tickled to be invited to participate tonight in this very exciting adventure. And I thought that I would take a few minutes and talk to you sort of at a 10,000-foot view, an overview of managing sexual dysfunction in multiple sclerosis, something that I've enjoyed doing for about 2 decades. So to set the stage, when we think about problems in the bedroom, I like to divide my thoughts into what I refer to as primary, secondary, and tertiary sexual dysfunction. So primary sexual dysfunction, in my opinion, is where the circuitry of sex is jacked up. So in the setting of MS, literally the nervous parts of the nervous system that are involved in obtaining an erection, maintaining an erection, orgasming and ejaculating, or arousal and lubrication and orgasm, these are interrupted because of damage from brain and spinal cord. Secondary sexual dysfunction, which I think is more common, to be honest, is where symptoms of MS interfere with being sexy. So for example, if you're in the middle of intercourse and have an extensor spasm of your leg, you're not having sex anymore. You're writhing in pain and your partner's been thrown off of you and the evening is not the way that you planned. If you're in the middle of intercourse and lose your bladder, that's a game changer. And so those are examples of secondary sexual dysfunction where a symptom of MS interferes with Friday evening. Tertiary sexual dysfunction is also way too often seen and not addressed. And that has more to do with the philosophy and psychology of the human being not feeling like a sexy creature, feeling like an invalid or disabled and not someone maybe even deserving of sex. So as I launch into my lecture today, I challenge each and every one of you, tell me in your mind which I'm talking about. As I talk about a tip, you think about, is he helping primary sexual dysfunction? Is that for secondary sexual dysfunction, or is it tertiary? And with that preamble and a sip of apple juice, I would like to share with you 16 of my top tips for improving the bedroom in the setting of multiple sclerosis. Now, the first 8 are going to be very medically oriented, and the second 8 get a lot more fun. So stay tuned. And again, as I share the tip, you tell me whether I was talking about improving primary, secondary, or tertiary sexual dysfunction. Number 1, addressing cardiovascular risk factors. Yes, I know I'm an MS doc. Yes, I know that we're talking about multiple sclerosis, but the reality is if you have undertreated diabetes, untreated hypertension, if you're morbidly obese, if you use tobacco excessively or even a little, these are all things that can interfere with the quality of your life. They can interfere with your life expectancy, but as it relates to tonight's lecture, they can make it terribly difficult to achieve orgasm. That's right, you heard me. And many gentlemen find that their erectile function plummets as they smoke cigarettes. And so if you wanted to live your very best bedroom life, one of the key things to do is to address cardiovascular risk factors. Yes, that will make you live longer, but it'll also make the bedroom that much better. Number 2, thinking about medication side effects. So I'm an allopath, I'm an MD, and I prescribe medicines as part of my living. And doctors, I find, are remarkably good at giving out medicines. We give them out readily. Here, have a little more. One thing we're not so good at is removing medicines. And lotions and potions have side effects. And in fact, some lotions and potions used for very good reasons can destroy the bedroom. A very classic example is the class of medicines, the SSRI medicines, or selective serotonin reuptake inhibitors. These are medicines for depression like Prozac and Zoloft, etc. Outstanding medicines at managing mood in MS, but have a side effect of sexual dysfunction. And so I think it's very important as we're trying to enter the bedroom that we think about whether or not iatrogenically any of the medicines that we're using may be interrupting our fun time. Number 3 is specifically for gentlemen. Gentlemen, we have to be looking at your testosterone because in the setting of MS, if your testosterone is low, it actually drives your neurological disability faster. It can contribute to significant cognitive impairment, and as it relates to tonight's lecture, it can create problems with obtaining, maintaining an erection, and ejaculating. And so we routinely check all men's testosterone levels in the morning. And if it's low, we go through a process of testosterone replacement, which I'll talk about in a little bit. Number 4 is underappreciated, and that is treating depression. So people impacted by MS are literally twice as likely to experience a bout of depression compared to the general population. And unfortunately, in the setting of depression, we sometimes experience this phenomenon. The doctor term is anhedonia. So anhedonia, which is not a bad Scrabble word, means that stuff that we used to enjoy, we don't anymore. And it can make sex not fun. And it clouds everything yucky. And so if you are struggling with mood, feeling sad, blue, and depressed, treating it will not just help your day-to-day life, it'll help your nighttime as well. Number 5, whoops, that's not enough fingers. Let's try to do this correctly. Number 5 is treating neuropathic pain. So I want to teach you another doctor word, allodynia. Allodynia means light touch doesn't feel normal, it actually hurts. And all too often, people impacted by MS can have patches on their body where light touch is uncomfortable or downright painful. I want to teach you another doctor word, dyspareunia. That means that stimulation of the down theres hurts, and so sexual sensation can actually be quite painful. And unfortunately, this is all too common in the setting of MS. And even more unfortunately, very commonly, the partner doesn't know that's a problem. We're going to come back to that point. Treating neuropathic pain, whether that be with a pain cream or a pain patch, or by taking an extra Neurontin or taking an extra Lyrica in preparation for evening intercourse, is a really good idea because you don't want that to stymie the event. Number 6, along the same lines, is treating spasticity. Spasticity is all too common in MS, and it's a situation where your muscles don't play nicely in the sandbox. So you're trying to bring your hand to your face, except the tricep didn't get the memo and it's still trying to do that. And the result is a spasm, a cramp, or a limb that's hard to bend. And there's nothing worse than being right in the middle of awesome sex and going into a spasm of your buttocks. That's going to ruin the evening. And so stretching before intercourse, like a track practice, and taking an extra baclofen are all part and parcel to the foreplay, getting ready for the good stuff. Very, very important. Number 7 is treating bladder dysfunction. All too often, people impacted by MS can have difficulties with bladder. And there's nothing worse than needing to empty your bladder in the middle of intercourse, except, of course, emptying your bladder in the middle of intercourse. And so it's always a good idea to void before intercourse. And if you have trouble emptying, we oftentimes will provide a urinary catheter so someone can properly drain their bladder before they have sex, and that way you're guaranteed to have no problems. It's also, in my opinion, important to go to the bathroom after intercourse and maybe even shower to limit something called honeymoon urethritis. So when you have intercourse and there's vigorous rubbing and there's bacteria that can enter the urethra, and it's a setup for a UTI and very unpleasant. And so by taking a shower or washing after intercourse, you can limit that. There are some patients who unfortunately have very frequent problems after intercourse with urinary tract infections, etc. And in those situations, we will sometimes give them a prophylactic antibiotic that they take after intercourse to help stave off those UTIs. Number 8 is dealing with constipation. All too often, people impacted by MS are all bound up. And if you're FOS, full of stool, that can cause significant pain, it can worsen spasticity, and it can make intercourse painful and not fun. And so a bowel regimen, emptying yourself out, does a lot to help you in many, many different ways, including in the bedroom. And so if you're bound up and having problems with sex, get ye to the doctor and let's get you cleaned out. So those were 8 of 16 tips. I now want to turn our attention away from treating depression and treating testosterone and think a little bit about getting ready for sex, quite literally preparing your body to do what you're going to do. The first I want to talk about, so number 9, is thinking about alcohol. Now, I like alcohol very much, and I am not a teetotaler, and I'm not suggesting that you should be either, but alcohol is a sedative hypnotic. And if your plan is dinner and chair dancing and then a couple beverages and then getting lucky, that's fine, but it may interfere with sexual function. I also want to remind you that at least here in the US, the average MS patient takes 7 prescription medicines, which is a tremendous amount. And we have to consider what 3 glasses of wine would do mixed with all those medicines. The last thing you want is to go out for dinner with the plans to have an awesome night, and then you fall asleep and someone has to tuck you into bed. So we have to consider alcohol as we plan our evenings. Number 10 is underappreciated. You need to get in shape. You need to condition your body to have awesome sex. When you think about the needs of exercise physiology in the setting of MS, there's really 4 categories. One is strengthening, one is flexibility, one is balance, and one is cardiovascular endurance. Now, all 4 of those are going to help you walk and not fall, and they will also help you have amazing blood-curdling, toe-curling sex. I want you to strengthen your buttocks and your back. I want you to strengthen your hamstrings and your quadriceps. I want you to strengthen your abs. Why? So you can perform better in the bedroom. Similarly, if you stretch out, you might get into awesome new positions that you didn't know was possible and improve the bedroom experience. Endurance and balance, those make a lot of sense. And the bottom line is, if you want to optimize your bedroom activities, physical therapy takes on a whole new meaning. Now, taking that a step further, I want to introduce to you what I consider to be literally a secret weapon. This is one of my favorite recommendations to make to a family, and that is pelvic floor physical therapy. Pelvic floor PT is the jam. And I remember the very first time I met a pelvic floor PT, and she said, hey, listen, Dr. Boster, you got to tell the patients, I get them up in stirrups and I get up in their business. And she helps them learn to reactivate all the muscles of the pelvic floor. And that is a game changer for bowel, bladder, and bedroom. And so if you're having trouble in the bedroom, one of my key recommendations is to get ye to the pelvic floor physical therapist. Super awesome. Number 12 is energy conservation. Now, people impacted by MS do well to manage their energy throughout the course of their day. And I want to focus on energy conservation as it relates to sex in 2 ways. The first is the timing of intercourse. So oftentimes we may engage in sex at night because that's when we see each other and that's when the kids are asleep. Except many of my patients have the least amount of energy in the evening. They're running on fumes since about noon or maybe 5. And so for many, many patients, that is a terrible time to have intercourse. Oftentimes, my patients find that they have the most energy in the morning. And so you may have to game out how you optimize sex during a window when you have the most energy. It's pretty important. Secondly, we need to think about the positions of sex. And so some sexual positions are going to require more energy than others. And as we'll get to in a little bit, there needs to be a very robust discussion about, hey, that doesn't work for me. My leg goes into spasms. I can't hold that position very well. My balance isn't very good. Let's try something different. Coming back to that point in a second. Number 13 is assist devices, which in the United States are referred to as sex toys. So think about this. Many of my patients use assist devices. They may use an ankle-foot orthosis. They may use a cane or a walker. They may use spectacles. And there's no reason not to use an assist device in the bedroom. Now, my fave assist device is a water-based lubricant and a plug-in-the-wall vibrator. And I'm a big fan of the Hitachi Magic Wand. They've never sponsored me, but if they wanted to, I would say yes, because I love their product. It is a plug-in-the-wall vibrator. Now, hear me out. When there's damage to the spinal cord and the down theres get stimulated, the message has to go all the way up the superhighway, the spinal cord, to get to the supercomputer, the brain. And because of the damage in the spinal cord, sometimes the message dies. And so a normal message is inadequate. Now, as I speak to you, I'm using my indoor voice. I'm not screaming because there's no interference between my mic and your stereo or your speaker. If, however, I had my entire clinic team in this office and they were all talking and screaming, I would be yelling at the top of my lungs. I would be providing overdrive stimulation so that you could hear me. We can use that same concept with sex toys to help with intercourse. If you use a water-based lubricant, it increases skin sensitivity. And then if you apply a plug-in-the-wall vibrator with a DC battery, we can have overdrive stimulation to send an adequate message that the spinal cord is surpassed. We get up to the brain and the brain says, oh, I know what we're doing. And it can finally send a message back down for lubrication and orgasm or for erection and orgasm. Sex toys are your friend. I want to share one other sex toy that you should buy, which is a swing. So a sex swing, and if you're not sure what I'm talking about, please enjoy Google later on this evening. A sex swing will allow you and your partner to minimize energy expenditure and maximize enjoyment and creativity. And so try out a sex swing. Assist devices are awesome in the bedroom. Number 14 are medicines to help men with MS. And I'm getting a signal that I'm way over, so I'm going to try to talk a little faster. I apologize. So many men are familiar with a little blue after dinner mint, Viagra or Cialis or everyday Cialis, and there's a multitude of medicines that can help with erectile function. Sometimes those medicines don't work, and then we can use an inner cavernosus injection. So literally an injection of a medicine in the side of the penis, and that's extremely effective. And if that doesn't work, we could actually implant a prosthesis. So when you're discussing erectile function, my question to the gentleman is, how hardcore do you want to get? How serious are you about having an erection? Because we can help you, I guarantee. Now, in reality, there are more medical options for women than men. And I'm shocked that many women don't know this. And so I talked about using a water-based lubricant. You can also, through a prescription, have estrogen cream. Estrogen cream rubbed on the down theres does not provide systemic estrogen, but it can help provide adequate lubrication and engorgement of tissues and can really help in the bedroom. There is actually a medicine, trade name is ADDY, ADDYI. Fluvoxamine is the generic name, and it is FDA approved here in the US for female hyposexuality or low libido. And it is a fantastic medicine taken once a day. We call it the little pink pill, and it can help a significant amount with female sexual function. Lastly, I oftentimes have a compounding pharmacy compound something called Scream Cream, which is exactly what it sounds like and causes blood flow to rush into the down theres and can massively help. Now, my last tip is my most important, and that's talking to your partner. Sex is intimate, and any intimate situation necessitates discussion. If you're getting on a boat with someone and you're terrified of water, you need to tell them before you get on the boat that you're scared. And similarly, as you game out how to enjoy sex, it's very important that you sit down with your partner and you lay it out for them. Say, hey, listen, here's some things that work really well. Here's some things that do not work very well. And here's 5 things that I'm dying to try. What do you think? My name's Aaron Boster, and as always, thank you for learning about MS with me. I am honored that I got to speak to everyone this evening, and I'll turn the mic back over and invite my colleague up on stage so that we can field your questions.
Thanks for that, Aaron. I'm going to just quickly introduce myself. I'm Margaret McGrath. I'm a senior lecturer in occupational therapy at the University of Sydney. It was great to have 16 tips and really nicely compiled for us. I think there's lots of questions. Peter, did you want to share those questions with us now so that we can respond and have a discussion?
Yep, absolutely. So we've got our first question here. Viagra is wonderful, but planning for sex eliminates opportunity for spontaneity. What's your thoughts on this?
I'll propose 2. 1, talk to your partner. So have a discussion. Say, hey, I would really like to see you naked. When's a good time tomorrow, right? And you can plan out when that's going to happen. Another option, there are, for example, medicines like everyday Cialis, which is a once-a-day pill, which helps with erectile function throughout the day. And so that's a conversation to have with your doc. Dr. McGrath, any comments?
Yeah, I think it's a common complaint, as it were, from people that spontaneity sometimes goes out the window. But I think in some ways, if we can reframe it, that all sex doesn't have to be spontaneous even. And in fact, for many of us, sex is not spontaneous. We have this maybe movie idealized, sensation that people suddenly decide to have sex. But for most people, sex involves at least a little bit of planning.
And so, a lot of planning, like next Thursday at 7 p.m.
Yeah, because for lots of life gets busy for lots of different reasons. So exactly. I think firstly, don't be too focused on the fact that it must be spontaneous. There are options, and I think have that conversation with your doctor. Talk to your doctor and say, you know what, I'm interested in Viagra, but I've heard that might impact spontaneity. Is there another way around this? Is there something else that we could try? Yeah.
Spot on.
Great. So Kerry asks, is there a female equivalent of Viagra, which Dr. Boster, you did cover?
So I don't know the trade name in Australia. I have trouble pronouncing the long generic name, FLIBANSERIN. It's a daily pill which can help with female low libido. Dr. McGrath, is that available in Australia?
I think you would have to consult with your individual practitioner. Certainly, I'm not entirely across, I'm not a prescriber, so I'm not entirely across medication, but I do think it's worth having the conversation. And again, you know, the conversation might lead you to different pathways as well.
That's exactly right.
Are there some more
Great.
questions, Peter? Yeah.
We've got a question here from Matt, just asking Dr. Boster if you were able to share the 16 tips, if they're written down somewhere, or are you able to share those post-webinar?
I do believe that this video will live on your website, and so that's one option. I have a YouTube channel, and I have a whole host of videos on sexual dysfunction, including a video with these 16 tips. So a couple different locations where you can find it. But I would encourage you to rewatch this on the replay that you guys produce.
Absolutely. And then just a number of comments that have come through. So Matt says, thanks, Andrea. Thank you, Aaron. William, very engaging presentation, Dr. Boster. And Marianne, Dr. Boster, that was an outstanding presentation. Talking with your partner is the most take-home message for me. So, sorry, we've just got one more that's come in from Matt. How do you best manage sexual dysfunction challenges with low partner libido as well?
So I strongly suspect that our next lecture will answer that in spades. The key is to talk to your partner. And I have had several clinic visits where we're holding hands, and that's what we're doing, is gaming out how the two partners can make it work. It's really it can become an awesomely fun game. And with no further ado, Dr. McGrath, I cannot wait to learn from you.
Thank you. So essentially, following on from Dr. Boster's presentation, communication is key. And it didn't surprise me at all when 64% of people said, I haven't had the opportunity to discuss this with my neurologist or my MS team, but I'd really like to. Because let's face it, none of us are very good at discussing sexuality. It's not a skill that we necessarily learn. And a lot of the time, our values and our cultural awareness of how sexuality should be experienced, how it should be expressed, tell us that this is something private, something that we shouldn't talk about, that's maybe something a little bit taboo. And I just want to quickly remind people that when I talk about sexuality, I'm not just talking about sex. Of course, sex is important, but there are other aspects of sexuality that lead us up to either wanting to participate in sex, having great sex, or maybe feeling less sexual than we might want to be. So remember that sexuality is everything that encompasses your identity. It's how you express yourself, how you dress yourself, how you engage in conversation, how you flirt or don't flirt, what kind of roles you participate in within the context of your relationships. Are you the caregiver? Are you the provider? Are you a parent? Are you a partner? There are lots of different aspects of our sexuality, and all of them can be impacted by MS. Dr. Boster referred to this idea of 3 categories of primary, secondary, tertiary sexual dysfunction associated with MS. And I think that's a really good place to think about, starting to think about how do I ask questions about each of those things. So when I think about the silence that surrounds sexuality, and one of my life's mission as my researcher is to end that silence, I wonder, why does it happen? And mostly it happens because of the values that we have about sexuality. And for many of us, those values say that sex is something for young people, for heterosexual people, for men, it's about penetrative sex. And it really only happens for people who are young, fit and healthy and body beautiful. Those are the images that surround us in everyday life. For many of us, it's about reproduction, at least some of the time during our lifespan. It's about monogamous relationships. It's about participating in particular forms of sexual activity. And sometimes that can go out the window, but it does shape how we understand sexuality. And the important thing to remember is that if 64% of you have not had the opportunity to discuss sexuality with your providers, it's probably because many of your healthcare providers also share similar beliefs or have similar expectations about sexuality. And my research tells me that up to 85% of healthcare professionals feel very scared to have this conversation with their patients. They worry about causing offense. They worry about not being able to answer your questions. They worry about not understanding what your sexual activity might be. They worry that they might say the wrong thing, and so they avoid the topic. But the really unfortunate thing is that they also assume that if it's really important to you, you'll bring up the questions. And so we get this stalemate. Patients don't ask because they're scared, they're not sure, and providers don't ask because they're assuming that if there's no noise about it, it's not important. So the goal of today is really for me to give you some ideas about questions that you could ask, and to give you some language for asking about support and advice and help with sexuality, because we know that it's important, and we know that in order for you to experience your sexuality in a way that matters and makes sense to you, you might need to have some support along the way. So if we start with the idea of primary sexual dysfunction, so we're talking here about things like, erectile dysfunction, difficulty with lubrication for women, difficulty with reaching orgasm because of the impact directly of MS. What kind of things could you say to your healthcare provider? Well, for healthcare providers, when I talk to them, I say, well, let's normalize the situation, and maybe it helps for you to normalize the situation. So a conversation might go along the lines of, I've heard that lots of people with MS find it difficult to have an erection. For men, having an erection can be problematic. And I'm having some problems with that. Is that something you could help me with? And that opens the door to the provider to say, oh, okay, yeah, that's something I can help you with. Or maybe, and it's possible, so be prepared for this. Maybe the provider is a bit taken aback and goes, I don't know about that. And so if they say, oh, I'm not sure about that, or I'm not able to help you with that, well, then the next follow-up question from you might be to say, if you can't help me, could you refer me onwards to someone who can? And there are lots of services. It might be a referral to a urologist, it might be a referral to a sexual counselor, to a sexual rehabilitation service. These services exist, but often people aren't aware of them and they're not sure how to ask for them. So yes, ask your provider. I've heard that for women, having orgasm can be difficult because of vaginal dryness and pain. Is that something that I can discuss with you, or is there someone else on this team that's better able to handle that? It might not be the neurologist, it might be your nurse specialist, it might be your occupational therapist, it might be your physiotherapist. It might be a whole combination of both, of all of them. But the important thing is that you can ask that question. Now, that might seem like a very direct question, and for some people, talking about erectile function and orgasm is difficult. And it does take practice. So you might want to role play it with your partner. If you're having problems with orgasm, or if you're having problems with erectile dysfunction, talk about it. Say, on that next visit, I'm going to ask about this. This is what I'm going to say. Practice saying the words so that you can say them calmly, that they come out of your mouth in a very reasonable pace and you don't look flustered. Practice having your partner there if you want them there for the discussion, so that they too can say, yes, this is an issue and it is important to us because it's impacting our quality of life. If we're thinking about secondary dysfunction and we're talking about things like fatigue and pain, possibly bowel and bladder dysfunction, again, talking to your provider and saying, have you ever come across patients who void their bladder during sex? What do? I want to know. Might be in an MS support group. Has anyone had an accident during sex? It happens, and there's a way around it. Of course, voiding before sex is important, but sometimes that doesn't happen. So maybe it's about thinking about having that conversation with your partner and saying, there's a possibility this could happen. I want to let you know so that you don't freak out. Or you have extra towels or sheets on your bed so that, or wherever you're having sex, so that there's a possibility to clean it up quickly. And when I talk to people who've had these situations occur, one of the biggest tips they've said is keep it humorous. There's nothing worse than being freaked out by something happening, but it's happened at this point. There's been a bowel accident, there's been a bladder accident. You just got to get on with it. And if you're comfortable enough with the situation, and if you've thought about it might happen in advance, and you thought, well, what would I do if that happens? Well, maybe I keep some wipes handy. Maybe I keep some extra towels handy so I can clean it up quickly and continue on. Or maybe I've had a discussion with my partner and they know, if this happens, don't panic. We'll just figure it out as we go through in the situation. In terms of the other issues around sexual aids and advice, again, your providers will be able to give you support, but they might need some prompting for you to say that I'm interested in finding out about things. There's a whole range of assistive devices to support orgasm, sex toys. Some of them are available through funded sources. Some of them you might have to purchase privately. The internet is really the great leveler in this, because there's lots of ways that you can discreetly look at this if you're feeling self-conscious about it. But I'd also say ask your occupational therapist, ask your physiotherapist. Do you know what are the best positions for me to have sex in? or thinking about the positions that I'm using, these are the difficulties I'm experiencing. So for example, I recently worked with a young person who was talking about wanting to have sex in the missionary position, but not having sufficient upper body strength. Now, what a great goal for physiotherapy is to work on upper body strength so that they can maintain positioning during sex. Much more interesting perhaps than working on upper body strength just so that they can work on upper body strength. It's nice to have a great goal in the end. And the physiotherapist was, of course, absolutely happy to work with that, but had never really thought about it because it hadn't come up in the conversation. The final part was around tertiary sexual dysfunction, and that's when people start to internalize beliefs about what it is to be sexy. Can people with MS be sexual? Is there opportunities for people to engage in sexual activity, or is that appropriate or normal? And of course, the answer is yes. Our sexuality is inherently what makes us human, and it's not taken away simply because we have a chronic disease or an illness. It just means that we might express it differently to what the standard or normative ideal of sexuality is. But until we start having conversations, it's very hard to change what people expect around it in terms of sexuality. So the question of how do I make myself feel good? Well, it's about talking to your partner. It's about thinking of ideas that make you feel good, things that make them feel good. If you're not partnered, it's about thinking about dating and how do I explain to people, well, I've got MS and this is how I might want to approach sex. I might want to do it a little bit differently. I might want to do it at different times. I might enjoy different aspects of sexual pleasure. So I think the key message for me is to be brave and to ask the questions. But in being brave, you need to practice. So if you can role play with yourself and with each other, might sound a bit silly, but if you can stand in front of a mirror and say to yourself, next time I go to my neurology appointment, I'm going to ask my neurologist about erectile dysfunction and say, look, I've been experiencing this problem and I want to have some help with it. If you're not comfortable with the neurologist, it might be that it's the MS nurse specialist. If you want to talk about vibrators or sex toys, you might want to talk to your occupational therapist. And if they look at you blankly, simply say to them, the follow-up question is, if you're not sure about this, can you refer me to somebody who is able to help me? Because it's a very legitimate part of your intervention, a very legitimate part of rehabilitation. And I really strongly encourage you to give it a go. Now, part of what we wanted to share today is, and my background is I'm a researcher in occupational therapy, and one of the projects that we currently have ongoing is one around communication and intimacy. So I'm really hoping that I might encourage you to participate in that. It's part of Claire Palmer, who's here with us today, honours thesis at the University of Sydney. And we want to look at how people with communication impairments associated with MS how that might impact on intimacy. So very grateful for anyone who might be interested in participating in that. I'm very happy now to take any questions because I see there's some coming in through the chat. Thank you.
Dr. McGrath, I have just a slide here with the QR code. Would you like me to share that quickly so people might be able to scan that?
That would be wonderful. Thank you. That's it. Great. Thank you very much.
Great. Well, I'll keep that up as you two talk. So there were a few comments that came in, no specific questions. Let me just see. Bruce has just said, and sorry, I'm not entirely sure what this is in relation to, but not feeling an orgasm and feeling too much are weird. That's sort of just a comment.
So
I'm not sure if you want to speak to that.
Yeah, I think it's a very common experience of hypersensitivity and yet not being able to orgasm, right? So, and it might be that this is an opportunity to explore different aspects of your sexual response. One of my good colleagues refers to it as not intercourse but extracourse, right? So thinking about alternative ways to have sex. We're often primed to think that sex has to be for heterosexual couples, penis and vagina. And it has to be about ejaculation, it has to be about orgasm. But in fact, there's a lot of sexual pleasure that's involved in the lead up to that. And it doesn't necessarily, we don't have to focus on this as a goal. Sometimes focusing on the goal of orgasm can be really off-putting and can actually make sure that we don't have an orgasm. And I think, Aaron, you're going to jump in there. Yeah.
Something you said resonated in that sometimes we have to talk to the partner who doesn't have MS, because they're upset that the person with MS is not able to achieve orgasm. Now, the person with MS is not upset by that, but their partner is. And so it goes back to something that you said during your lecture, which is so important, is that it's talking. The discussion is so key. So often, if we engage in a conversation, we can find a solution, a creative solution. Also, as it relates to hypersensitivity, there are medicines that can assist with hypersensitivity. And so there's a host of things that we can try pharmacologically, and even certain condoms and things that can assist with that. So again, bringing it up to your clinician so that you can game out how to make it better is a really good idea.
I like the idea of using the term game as well, because it sort of makes you relax a little bit about it. And sex should be relaxing, it should be fun, it should be enjoyable for everybody. So I think if we can reframe it from I must have sex, I must have an orgasm, to I must be able to enjoy intimacy with my partner or with myself if I'm not partnered. That must be fun for me. It might add to my sense of well-being. It doesn't have to end in orgasm. It doesn't have to be in any particular way. Sex can just be what I want it to be.
Amen.
And I think that reframing it can be helpful.
Super helpful.
Great. We don't have any other questions that have come in. So unless you two want to keep chatting, I will throw on Dr. Sinead's pre-recorded video for anyone.
I can't wait to see it.
Yes, for anyone that wasn't aware, Dr. Sinead Hines couldn't be here. She lives in Ireland, and the time difference is just too difficult. So we do have a 15-minute pre-recorded video. So please sit back and have a listen. Thank you, guys.
Hello, thanks very much for inviting us to talk here today at your event. Unfortunately, I'm not great in the middle of the night, so we have this as a recorded presentation. My name is Sinead Hines, and I'm going to be presenting on behalf of myself and my co-authors, Kinza Tabazum, Jackie Fox, and Sarah Fuller. So what we're going to talk about today is research that we carried out in 2020, so 2 years ago now, that was on the topic of dating with a diagnosis. So we were specifically looking at the lived experience of people with multiple sclerosis. So just as some background, multiple sclerosis usually manifests during early adulthood. So this is a critical period for the development and maintenance of relationships. And we know that MS symptoms can affect a person's ability to participate in meaningful activities, and these include relationship-focused activities, things like dating, preparing meals for other people, engaging in sexual intercourse with others, and things like that. So previous research has explored the experiences of people with MS in long-term relationships and marriage. And it's been known that dating or entering romantic relationships has been shown to be difficult for those with physical disabilities. These people often face stigma, negative social attitudes, and have the fear of requiring care from potential partners. So although research exploring the dating experiences of people with MS is sparse, studies involving those with physical disabilities do demonstrate how stigma and anxiety can be associated with a kind of burden of care that people sometimes expect. So the dating experiences of people with MS may be very different, and that can be because people, you know, they often have symptoms associated with the condition that are invisible. So research suggests that invisible symptoms of MS, so things like pain, fatigue, cognitive problems that are sometimes present with people with MS, that they can have significant impacts on social interactions, because they kind of have it impacts on kind of a mismatch between how the individual appears on the outside and how they appear internally. So we know that a diagnosis of MS can impact on family relationships, marriage, and long-term relationships. We know this from previous research in this area, but we know very little about the experience of dating. So the idea of dating as an occupation and how people maintain romantic relationships with the diagnosis of MS. So that's what we are aiming to do then in this research. So the objectives that we had for this particular research project were to develop a rich understanding of the impact of MS on romantic relationships and occupations related to dating, and also to have to better understand how living with progressive early onset condition such as MS interacts with or influences developing romantic relationships. So they're the two main aims that we had for objectives for this study. So just to kind of give a brief outline of our methodology, we used a descriptive phenomenological design. We collected data through focus groups. So these were online focus groups. The research was conducted kind of in the height of the lockdown in Ireland. So this was kind of summer 2020. We use a purposive sampling strategy to identify participants. So we needed people that had relevant knowledge or experience of the actual research topic. So that being dating and also having MS. So the participants themselves self-recruited. So we advertised for the study, and if people were eligible to participate, then they were invited to take part in a focus group. So the eligibility was that people were over the age of 18, they had a diagnosis of MS. And we exclude participants if they were cohabiting with a partner or if they were married, because we were really interested in that kind of pre-stage, so the dating stage. And we used Coalesce's descriptive phenomenological method to analyse the data. So I won't go into too much detail just for the interest of time, but this is kind of a brief outline of how we analyse our data using this method. So it's a 7-step method, or kind of 8-step, I suppose, but 7 main steps. And what happens is that the authors independently analyze the data. So there was 3 people involved in the data analysis section. So the first step is reading and becoming familiar with the data. The second step is identifying any significant statements relevant to the phenomenon of dating. Then we were looking at formulating meanings, then clustering these themes to develop kind of a rich description of the phenomenon that we were interested in. From that, then we produced a fundamental structure, as we called it. So that this was kind of the next step. And then following this, we sent this fundamental structure to the participants who participated in the research to get their ideas on whether they thought this was an accurate representation of what was discussed in the focus groups. So we carried out member checking with all of our participants. And then, yeah, so this was done to kind of have that accurate analysis of the lived experience and to make sure that we were accurately reflecting what happened in the groups. And then we wrote up and made any changes based on their feedback. So in terms of our results, we had a small group of participants, but we had quite a varied group of participants. So we had five females and 2 males who participated in the studies. The participants themselves were between the ages of 23 and 51. 6 had relapsing remitting MS, and 1 participant had primary progressive MS. And there was a bit of a range in terms of the time since diagnosis, so a range between 4 and 16 years. So there was 4 themes that we identified in the data using the method I just described. So I'm going to just kind of briefly touch on each of these 4 themes. I'd encourage you to read the entire paper that we wrote up and published on this if you want more detail than we can provide to you in the time that we have here. So the first, the first theme that we have is disclosing the MS diagnosis is the personal choice. So kind of what came across from the participants was that dating with a diagnosis of MS is effortful. So people said that it's more effort than if they didn't have a diagnosis of MS. There's lots around the idea of kind of decision making about when or how, or even whether you divulge your diagnosis. It's very personal, and we saw a lot of variety in terms of how people approach this, the participants that we had in the study. And this was often based on experiences that people had in the past. So whether it was a good or a bad experience that people had with romantic partners. So this is just, so I'll read out one quote here from a participant, and they said, "You can't relax into something properly until you've gotten that bit out of the way. It's just always in the back of your mind until it comes up. Like, how's it going to come up? When's it going to come up? What's the reaction going to be? Because there's always the possibility that it's going to be bad." So as a result of this, some people fear that having MS will reduce their likelihood of somebody wanting to date them. And that emotional impact of rejection due to MS can be significant. And this is especially the case for some of the participants in the study who were emotionally invested in a relationship, because one participant said, you think that you're getting on well with somebody, and then you drop the MS and they're just gone. which is quite soul destroying. So you can really see that it can be very challenging for people to decide whether to and how they were going to disclose their diagnosis of MS. And this particular theme, I think, is developed quite well in our paper, and it's an area that really we spent a lot of time talking about in the focus group, because everybody had quite different and similar experiences of disclosing the diagnosis during the dating. For some people, they said that what they did was, once they got to know somebody, they told them their surname, and they expect that they would look them up on social media. And then on social media, they're very open about their diagnosis, and they're involved in their local MS society and things like that. So they use that. So instead of having the discussion with people, that's the way that they tackled it. So there's different ways that participants in the focus groups looked at this idea of disclosing their diagnosis. So just to move on then, the next theme that came up was, we titled it, there's a negative or outdated perception associated with having MS that you firstly need to address yourself. So the reactions to receiving an MS diagnosis was mixed for the participants in the study. So sometimes it's difficult to deal with the emotional impact of the diagnosis, because people can feel vulnerable, they feel frightened, they feel unsupported or uncertain about the impact that MS can have on their lives, including romantic relationships. So people said that the narratives that are out there in the public consciousness and in media and things like that they can be very negative, and it can complicate how you were perceived as a potential partner by other people. So having the right information at the time of diagnosis was shown, or was said by the participants as being really important. One person said it was essential to avoid a full-on freak out. Another thing that came up as part of this was the idea of kind of having to constantly educate people, so potential partners, about MS and how that can be exhausting. So something that they were saying, or the participants were saying, that it becomes emotionally draining, and it can be really challenging to manage what they called the emotional labor of dealing with somebody else's fallout when learning about MS. So again, this is something that came up with that idea of having to educate people, and the need, I suppose, for clear, simple information that maybe they can guide people to, instead of having to talk to everybody all the time about their diagnosis. So some people only go into detail about their condition as well if they're emotionally invested in that person. So they make a decision on whether or not it's kind of worth it for them. There's a quote here from the participant who said, I would wait a little, just because it's emotionally tiring trying to deal with somebody else's response to it, and then kind of reassuring them. And it's like, do I really want to be spending my time reassuring someone? It's like almost twice as much energy is invested into reassuring somebody. So that was kind of another side, as well as disclosing. You know, in the first thing we saw that there's the impact of actually disclosing the diagnosis, and now you've disclosed your diagnosis and you're trying to kind of navigate that with the person. And a third theme that we had was that MS can impact dating and dating activities. So dating activities such as physical exercise or even intimate relationships are compromised by some people, but the individual and fluctuating nature of multiple sclerosis makes it complicated to explain to others. So hypersensitivity, for example, in areas of the body can make physical affection uncomfortable for people with MS. And this can have an emotional impact. So for one person, they said, it feels awful to shudder at the touch of your partner, tell them to stay away from you. You know, that's not nice. There's other activities that were mentioned as well, so things like dating activities that might be limited or restricted due to pain or fatigue. Some people spoke about having to cancel last minute or make some last minute changes because of how they're feeling, and how different partners might react to that. But they said that clear communication with your partner and developing strategies to facilitate understanding of the condition is really important. So the final theme that we had was online dating. So they said that online dating can be intense, but COVID-19 has been a leveler. So I'll just talk about this quite briefly, just for the interest of time. So online dating can provide an opportunity for people to meet more people, and that was seen as a positive by everybody, even those who aren't necessarily online dating at the moment. Some people find it easier to express themselves online compared to in person. And they said that online dating during COVID-19 has been positive because it's been a leveler. Everybody's kind of at the same thing. So people are, you know, meeting online, or they might be meeting for a coffee. Nobody's going to pubs, or, you know, the activities that people are doing are quite different, or at least were quite different at the time that we were collecting the data here. So everyone was doing the same types of things for dates. So they were saying that as a result, it's been a nice leveler. So ultimately, however, MS is only one aspect of the person, and acceptance of the diagnosis is an important characteristic that's worth waiting for in a partner. So that was something that came across. So people were willing, very willing to wait for the right person. So in conclusion, dating with a diagnosis of MS is a highly personal phenomenon. It's characterized by many individual differences in values and experiences. Core to this phenomenon were things like the process of personal decision-making around disclosure of the diagnosis, considerations about dating, couple-focused activities that were limited by pain or fatigue, ongoing adaptations to the fluctuating nature of the condition with partners in new or developing relationships, and planning for and engaging in dating and disclosing the diagnosis to dates or to partners was considered by some to be emotionally exhausting, as we said in the first point. So the findings were from this research, we're hoping will help guide healthcare professionals working with adults with MS, and also just help us to understand what the dating experience is like for adults with MS. So it's a very quick presentation of our findings. If you're interested in learning more on this topic or reading about it, the full paper is referenced here at the top. We're happy to share that paper with anybody who's not able to access it. It should be available open access, and these are some of our references, and my email address is at the bottom there.
So another great and informative presentation there from Dr. Sinead Hines. So yes, thank you very much, Dr. Hines, for that. So now I'd just like to run through a few of our services that we offer here at MSL. It's always great to let everyone know about what we offer, because we're here to support not only people living with MS to live well, but also for family, friends and carers, employers and health professionals as well. So many of these services are free to access, and I'll run through a few now. So MS Connect is the gateway to MS information, advice, support and services. Our MS Advisor service offers you specialised advice from either an MS nurse or social worker. We have an allied health services, including physiotherapy, continence support, exercise physiology and occupational therapy. The MS Peer Support connects you with a community of other people living with MS and their family and carers. And that's one that I would suggest using. People get a lot out of that. The MS Employment Service will help you to stay in your current job or find new employment. NDIS engagement helps you to understand and apply for the NDIS. MS Support Coordination helps you connect with the NDIS services. MS Plan Management helps you to budget the funds in your NDIS plan. And MS Financial Assistance Program provides one-off funds for financial hardship. So they're just some of the services that we offer. So please head to our website. You'll see those services there and plenty more as well. So we do have a number of resources as well. Our webinar library and podcast series are both accessible via our website, and they cover a wide range of topics from symptom management, living well with MS, NDIS research and updates, and personal stories of people living with MS. In Touch is our monthly e-newsletter where we share useful information about MS treatments, latest research, health and wellbeing, our services and events that you can get involved in. So please contact us to register as a client to access this e-newsletter. We also keep people updated with news as well as hold online events via our social media pages. To follow us on Facebook, Instagram, LinkedIn, or YouTube, search for MS Get Involved. And finally, contact us. You can contact us for more information or support Monday to Friday, 8 AM to 6 PM. Follow us on our social media channels to keep up to date on activities. And please do stay on after this webinar to complete a short survey. Your feedback is very important to us and it will be used to improve our services. So thank you very much for joining us today. I hope you've got a lot out of the session and could walk away with some practical tips on how to improve your relationships, intimacy, and communication. I want to finish by saying a huge thank you to Dr. Margaret McGrath, Dr. Aaron Boster, and Dr. Sinead Hines. It was a very informative and interactive hour, and we hope to see them presenting again at sometime in the future. And we hope to see you all again in the future as well. So thanks very much.